आपको परसों के ने लिख के देते उसको देने देना, परसों ही मेल कर देते उसको। मेल तो करोगे ना कि ये रहेंगे ना, ऊपर वो तो लगवाएंगे ना, ऊपर प्लेट तो लगवाएंगे ये लोग, प्लेट तो यही लगवाएंगे ना। नहीं ये तो बनवाएंगे ना यार, उनका तो फ्लैक्स वाला है जो बंदा है। हाँ स्टॉल के ऊपर वो लगाते हैं ना बाहर, जो उनका प्लेट है जो भी नाम लिखने जो, तो नाम तो वही लिखवाएंगे डीएमए वाले ही। मान लो लाइब्रेरी का, तो लाइब्रेरी का नाम तो वही लिखवाएंगे।
This has a high resolution.
This one.
आप 10 नाम बना के 10 नाम तो मेल करो, फिर मैं बोलता हूँ उसको। ठीक कर लो उसका। और जी अलेक्स सर,
both of them are calculated a formula for that compensation. Minimum 4 lakhs, maximum 70,000.
Sir,
This is
I need silent. नहीं है सर। हाँ चेक करिए मैंने पर सर, आप दोबारा से कर दीजिए। हाँ प्लीज। Sixty seconds.
greetings from Team IMA. I am Dr. K.K. Agarwal, the Honorary Secretary General. This is our weekly show, 3 to 4 p.m. every Thursday, and this is being brought to you courtesy Imatv Access on every week. With me today, on my left, is our National President, Dr. Imatv. Then Dr. V.K. Monga, the Dean-elect, who is going to take over as the Dean of IMA CGP in the next 2 days. Dr. Alex, our Joint Secretary to the President, Indian Medical Association. And on my right, I have Dr. Reshma, who was earlier at Delhi as a senior psychiatrist, and now she is in US and she's practicing life skills and she's teaching life skills. So the format of today will be that our national president, because he is going to hand over, a new president is going to take over on 28th, is going to give a address to all the members of IMA today. And then after that, we'll be interacting with Dr. Reshma on certain aspects of mental health and lifestyle, life skills. All to you, our national president, Dr. Matanda Pillai.
A very good evening to all of you, and also on the Christmas Eve, I wish you a very, very happy Christmas. As KK has already mentioned, our team is going to lay down the office on 28th. For 1 year, you have given us an opportunity to serve you and the medical community, and we are very much indebted for the confidence you have bestowed on us. We have been able to address many of our problems which a practicing doctor faces on day-to-day matters. We could identify many of the issues which have been more or less unaddressed, at least for 14-15 years, because a lot of legislations and Central Act had come, which have been, we could in a simple term say, it's not conducive for the doctors to practice with dignity, with peace, and with efficiency. To that extent, the service that we render has been little lopsided and not to the extent it should have been. To say a few examples, the PCPNDT Act, the purpose of the Act is to reduce or eliminate female feticide through ultrasound diagnosis. Of course, the intention is very good because the male-female ratio has to be maintained, and even for the survival of human species, it is essential that the male-female ratio is preserved. And I may definitely approve the objective of the Act. But many of the clauses of the Act, we find that are very much counterproductive. There is a criminal clause which attracts severe punishment for individuals, both doctors or technicians, who do female feticide, aid or abet female feticide. We agree on that point. We strongly support that part of the Act. But the same clause, 23, also attracts the same type of punishment. That is, attracts criminal punishment if for small non-compliance. Say, for example, if you don't display your registration certificate in your scan center, or you don't have a copy of the legislation or the Act in your center, or you are not wearing protective gadgets which you are supposed to when you do the examination, or if there are some mistakes in the form which again runs to 4 pages or 5 pages, some errors or clerical errors are there. All these non-compliance do attract same criminal clause of the Act, which I am strongly oppose. We have found that recently quite a lot of cases have been charged against doctors. When you analyze it, maybe 1% of these cases are genuine, in the sense there has been an attempt to do female feticide or abet female feticide. But all the others, we find that it's all trivial non-compliance, for which the doctors, criminal cases are charged against doctors and they are imprisoned. Of course, we have approached the court and definitely we have got stay. But our time need not be and should not be wasted in pursuing these matters and getting legal solutions for each and every case. So IMA strongly demanded to the government that this clause should be amended so that these trivial non-compliance should only attract penalty. We don't say you leave them scot-free, but then it should only attract penalties. So we strongly stand by that. Second is, of course, the Clinical Establishment Act, which has come into existence for the last 5 years or so. And the purpose of the act is to have uniform standards in health delivery throughout our country. Even that statement itself, we find, is very, very difficult to implement. Because in a country like ours, where so much of socio-economic disparities are there, and geographical obstructions are there, which really renders it impossible to have uniform standards in health delivery. And by any standard, any process of accreditation does not say that you have to have a uniform standard throughout the country. The accreditation standards are decided by what you offer to the patient. It may be a single-man clinic, it could be a multi-speciality, or you may be offering very advanced healthcare. So depending upon your objective for which the clinical establishment is there is a graded accreditation. Even the National Board for Hospital Accreditation, which is an autonomous body which has come into existence by an act of parliament, does only go by graded accreditation. Then how can the government insist on a uniform standard of accreditation or standard of healthcare? Here we have a lot of reservations. And more so, a country like ours, where we don't have enough of doctors. We have 1 doctor per 1,600 population. WHO says that we should have 1 in 1,000 population. And even to reach that target, in 5 years, we had to produce additional 3 lakhs of doctors. So unless that number of doctors are available, we cannot expect the healthcare to be distributed uniformly throughout our country. Even in the case of nurses, we should have 3 nurses per 1 doctor, in that proportion. We hardly have 2 nurses per doctor. That means most of the clinical institutions are forced to utilize trained nurses, in the sense that +2 qualified people are given training by the hospital itself and equip them to give nursing to the patients. So without having the proper ratio, we cannot insist on a clinical establishment to have this number of sort of trained and certified nurses by the Nursing Council of India. So such disparities, even the manpower distribution is there. And more than that, what we find is that a single man clinic, now we know, at least according to the national sample survey conducted and which has come out in 2014, it is a single man hospitals, single man clinics, family doctors and small and medium level hospitals, which is taking care of 40% of our healthcare. Even the government institutions like the primary health center and community health center can reach only around 10% of our population. So having said that, we find these restrictions which the government is going to bring in the name of Clinical Establishment Act and Uniform Standard, the survival, financial viability and survival of these small and medium level hospitals are going to be jeopardized. So instead of putting lot of restrictions on these hospitals, what I am demanding is that government should have a supportive clause. If we go through the whole act, we find there is no supportive clause at all. A time-bound sort of attaining of the standards which they are prescribing is not given. So once the act is in existence, next day onwards they inspect and find if deficiency are there, they are disqualified. And that's not the way one should go forward, particularly in a country where a lot of deficiencies of manpower, resources, and things like that are there. What we are demanding is that single man clinics or family doctors should be exempted from the purview of this act. Small and medium level hospitals should be sort of come under the category of aided hospital. If you can have aided schools, you know, education is a fundamental right of a citizen, and government to promote education have aided schools. Then equally important is health. Health itself is a fundamental right of a citizen. And why can't the government come out with a concept of aided hospitals, sort of encouraging the hospitals to attain the minimum standards through a lot of incentives, like maybe soft loans or even electricity charges. Now it is commercial charges, it can be made domestic charges, and things like that, small interventions. And also, it can even bring down the cost of treatment, even in the private sector, if there is a process of empanelment. The government can decide on a rate where each procedure ought to be done, and those hospitals which are ready to sort of extend treatment in that rate definitely can be empaneled, and to that extent the cost also can be brought down. So there are a lot of ways and means whereby the government can have some promoting clause also in this act, which is not obviously present. Then of course there is a clause which says that a patient has to be stabilized. Even if it comes to a family doctor, as per the clause, the family doctor is supposed to stabilize the patient before transferring to another center. How can this be done? Any medical man cannot agree to this clause, because stabilization in itself is a process where sometimes you may have to give definitive treatment. Say for example, somebody has come with myocardial infarction and the doctor tries to stabilize his blood pressure. And obviously a patient who has a heart problem, myocardial infarction, you cannot, without definitive intervention, you cannot stabilize the patient. He needs something to be done, either thrombolyzation or even stenting or whatever. We didn't say maximum of half an hour or 1 hour. If you don't offer that facility to the patient, you are going to lose the patient in the process of stabilizing the patient. Again, ectopic pregnancy and you have a hemorrhage. Here again, a definitive surgical intervention has to be done rather than stabilizing the patient by giving intravenous fluid. So such, if according to the act, if somebody attempts to stabilize a patient, then he is doing injustice to the patient and you are going to lose the patient. So such clauses has to be removed. If you say first aid has to be given, we can understand. First aid definitely has to be given. And at the earliest you transfer the patient to a center where definitive treatment can be offered. And another clause, there are so many clauses, but the major one I am just enumerating, is that at the district level, the committee which sort of register the hospitals and give accreditation or permission consists of the collector, DMO. What is the role of a superintendent of police in deciding on accreditation or checking the minimum standards of the hospital? What is it because of his medical knowledge that he has been put in, or to intimidate the hospital? We cannot understand the logic in including a police person in that committee. So such aberrations are there, which definitely are going to be counterproductive, and it is not going to serve the purpose for which the act has been brought in. So here again we strongly oppose these clauses. There are so many other clauses, but these are main clauses which oppose, and we have given representation to the government. Hopefully we will be getting justice from the government. Third is, of course, when there is negligence or when there is a grievance on the part of the patient or the relatives, we definitely understand that there has to be a mechanism whereby the grievances are addressed. We already have the Consumer Act, Civil Courts, Criminal Courts, Medical Council of India, and also the Human Rights Commission and Human Commission and so many other commissions where complaints regarding deficiency of service are being given. And each and every of this body is asking doctors to give explanation and trying to solve this. Here again, to have multiple number of avenues for redressal of a grievance itself is against a basic law, and it is a denial of natural justice to the profession. Because in one court, you are exonerated. They go to another court, and then they go to another forum. So it is an endless process for an innocent doctor to spend his life in courts and commissions rather than concentrate on patient care. Of course, that part apart, what we find is that the people, the antisocial elements, taking the law into their own hands and assaulting doctors and causing destruction to the hospital. I'm sure that any civilized society can approve of people taking law into their own hands. We are very sorry that if the civil society, the media, the authorities, or the judiciary never take cognizance of this fact and so moto intervene to solve this. So it has become the responsibility of the medical profession to take up this challenge and see that there is a central act whereby there is protection is offered to institutions, clinical establishments, and the health providers, so that a doctor can work without fear, with dignity and peace, so that he can give the best to the patient. Not only that the doctor is directly involved. When a hospital is attacked, there are so many patients lying in the hospital. They may be in the verge of delivery, or they may be having a myocardial infarction or other serious illness, or even hypertension, uncontrolled hypertension. When the hospital is attacked, where these patients are lying down, what will be the psychological trauma that these patients will be subjected to? Who is bothered about this? Definitely, this has to be stopped. In a civilized society, this should not be allowed to happen. We also know that it is not the close relative of a patient or the aggrieved family which is resorting to all these antisocial and violent activities. Many a time we find that there are disgruntled antisocial elements who have a grudge against a hospital or a doctor. They wait for an opportunity and utilize it to seek vengeance against the hospital. That is what we have found when you go through all this. And this has now become a day-to-day affair. We always say that every minute there is an accident happening in Indian roads, and so many people are lost. Similarly, every day there is an attack on a hospital or a medical person somewhere in our country, and this should be prevented. And IMA strongly has taken up this challenge, and we are with the doctors. Then, of course, another issue which in the larger interest of public health that we thought we should intervene and address is allowing other systems of medicine people to practice modern medicines, prescribe modern medicine. This again, we feel in the larger interest of the public health, that should not be allowed. There have any number of court verdicts which definitely says that other systems of medicine should not prescribe or practice modern medicine. A lot of court verdicts are there, both at the district level courts, high court and even Supreme Court. In spite of that, we find that government is promoting this. Definitely we know that even when a modern medical doctor practices and prescribes medicine, in spite of his intense training during undergraduate period or even during postgraduate period or subsequent CMEs which he attend regarding prescription, yet the number of iatrogenic complications are on the increase. And you imagine a person who are never trained in modern medicine or prescribing modern medical drugs is allowed, given license to prescribe modern medicine, and you can just imagine what will be the incidence or percentage of iatrogenic complication that is going to happen. So here again we strongly object this. So these we have identified as 5 major burning issues of the medical profession. We have declared November 16th as a protest day, and sensing the support that we have at every level from every practitioner of medicine, government called us to the negotiating table. Government has formed an inter-ministerial committee to examine these issues. We already had 1 or 2 sittings with the government, and many of our sensible arguments that we have put forward, government, I believe, is more or less ready to accept. We are having another meeting on 5th of January, and maybe within 1 or 2 sessions, hopefully, many of these issues may be addressed. Of course, due to lack of time, I'm not going to other details, but then we have been addressing almost all the problems of the medical profession. We have launched newer schemes like pension scheme, health scheme, biomedical waste disposal scheme. Then welfare activities like prevention of blindness and diabetes, and drug addiction, Avoga and Chale programs, adolescent empowerment programs, safe sound initiatives, digital IMA, those things. Then other areas where we thought rather than putting all the blame on the government, we had to have some introspection and see that we correct ourselves towards that end, to inculcate or increase the knowledge regarding ethics, particularly bioethics among medical graduates. We have embarked on a program of training the medical teachers on ethics, and also to see that ethics is taught to the students, not only at the non-clinical level, but even during the clinical posting by a process of vertical integration, so that even a cardiologist, when he teaches an undergraduate on myocardial infarction, he is supposed to also address the ethical aspect of treatment of myocardial infarction or any other disease. Another initiative that, a similar initiative that we have taken is to sort of voluntarily go through a process of accreditation for small and medium level hospitals, because we believe that many of these problems that we face, including attack on hospitals, can be at least to some extent prevented by professionalization of management of the clinical institutions. Towards that, we have an MOU with the NABH, which is the accrediting body, and promoting entry-level accreditation. Here I must definitely use this opportunity to profusely thank our Secretary General, Dr. K.K. Agarwal. We think alike, we work in unison. And I'm sure that during the years of the IMA office period, a president and secretary who have same ideas, same commitment, and work in unison, we never had any difference of opinion. And he is a strong pillar of support to me to sort of implement whatever we have decided. We together decide the agenda, we together work. I am particularly compliment my Secretary General, Dr. K.K. Agarwal, for the strong support he has given. Also, the communication, digital IMA initiative, that is particularly he is the author of that. And this has definitely helped not only in disseminating information about what IMA is doing on all these fronts, but again, On academic areas also, this has been very handy to many of our doctors.
Thank you.
And last but not the least, we could achieve and we could strongly define these things only because of the support from branch level, state level, and individual doctors have given us, and the confidence you have given us, and the empowerment you have given us to go ahead and fight for the cause of the medical profession and public health. Thank you.
Thank you, Dr. Pillai. And so that's his address. And as he said, we have an interministerial meeting on 5th, and we'll come back to you with more details. Now we come back to our subject of mental health and life skills. I have with me Reshma. Reshma, just give us a brief about what is life skills on one hand, and two is what a GP must know on simple basic mental health. Why I'm asking this question is because in our medical college, we were taught mental health as one class for the whole division. But when we come to practice, 30 to 40% of it is mental counseling. And now MCI has come out with an amendment. That amendment is likely to come any time. And they say that out of 30 hours of CME credit hours, 10% of it has to be on mental health.
Better late than never.
So they are now making it compulsory that every CME must have some mental counseling session. So first of all, what do you mean by your life skill coaches?
So there are two things. One, you said how.
And before that, people have already started asking questions. You can be on emedinaccess.com, where like a Facebook, you can put your questions and we are answering together. And you can also you can also SMS your questions to 98101-18256 and 98110-90206. So you have three options. Either you go back to the phone, put your question as SMS, or you can also go to emedinaccess.com directly, and like a Facebook, you can post your comments and ask questions. Go ahead.
So two issues. One is how general practitioners can treat or manage mentally ill patients on a scientific, evidence-based way. That's one. And second, you said about life coaching. We'll come to that
Life
later if we have
later.
time. Let's focus on this because I have been very, very actively engaged in training. Do you want me to look there or? Right. So I've been engaged in GP training, practically all my psychiatrist life, and I know the kind of issues that GPs face. So let's talk about that, because GPs, when I was training them, they were coming up with very similar questions, and the most important of them was, how do you differentiate between normal and abnormal psychiatric symptoms? Patient comes with anxiety, patient comes with sadness, palpitations, restlessness. You can see that they have anxiety symptoms, you can see that symptoms of depression. How do you know whether they are normal or abnormal? So I want to share with everybody that the first thing that you must focus on is, are the symptoms limited to one situation or are they pervasive? That's the first P. Pervasive. So every human being spends their time in three situations. One is home, one is work or an educational institution if they're students, or in the society. So if you find that the symptoms are limited to a situation, for example, a lady has only problems at home, she goes to to her mother's house or to work or to school or to a kitty party or whatever, at any gathering, social gathering, everything is fine. At home you find a problem, then the problem is in the situation, problem is outside her. Likewise, a male may be having some issues at work, he comes home with friends, everything is fine, going to work, anxiety, sadness. So you can differentiate between normal and abnormal symptoms by the first P, which is pervasive over situations. So if you have symptoms which are two or more situations, then it's a problem which could be potentially a mental illness. That's one. The second P is persistence. So I lose my wallet, I've forgotten this, I had a little issue temporarily, I react to that. So I could have any psychological symptoms, but they may subside because there was a stressor outside me and I was only reacting to them. So that's the second P, persistent. Make sure that the symptoms last for a bit, and that's the tricky part. no psychiatric illness is diagnosed by testing. There's no test. So everything is a clinical diagnosis, and we have diagnostic guidelines, and that's again the tricky part. शुरू से हम सुनते आए थे कि साइकियाट्री में कोई प्रॉब्लम नहीं है, 4 बीमारियां हैं, 4 दवाइयां हैं, ठीक किसी ने होना नहीं है, क्या फर्क पड़ता है? But now we do know, even ICD-10 will give you hundreds of psychiatric diagnoses. There are hundreds of psychotropic medications, and all that is important in psychiatry is to make the correct diagnosis, because the entire management becomes different, For manic, what used to be called manic depressive psychosis, now we call bipolar affective disorder. The management is totally different. So you see a patient with depression, and if you don't take good history, and you miss a manic episode in the past, you miss a diagnosis of bipolar affective disorder, you start an antidepressants, patient switch to mania, and you get a bad name, and then people run to alternate systems of medicine, and they blame us for mismanaging. So that's very, very important. Every diagnosis of a psychiatric illness is based on diagnostic guidelines. So just as an example, if there's sadness, if it is at least for 2 weeks, you consider depression. If it's for a few days, you follow up the patient. If the patient has short-standing anxiety symptoms, you know something is not right, so you keep the patient on follow-up, and if we'll go to the next step. So at least you know something is abnormal if it is pervasive over situations and is persistent over time. Mania 1 week, depression 2 weeks, anxiety 1 month, like that. So those are the two P's.
Mania.
This is a rule of the thumb. It's all in ICD-10. If somebody wants to mug it up, 7 days, mania, 2 weeks, depression, major depression.
2 weeks is
major depression. Like anxiety disorders usually be 2 weeks to 1 month to 6 months. What used to be called anxiety neurosis, right? Generalized anxiety disorder. So approximately, I would say rule of the thumb 2 weeks. I would say mania gets caught out very easily. And somebody is manic, spending money, active, singing songs, cracking jokes, personality becomes totally different. It's very easy to recognize. But most, I would say, get your radar up if it is 2 weeks. 2 weeks is critical. If somebody has, again, not 2 weeks would be most of the day, most hours of the day, for most days of the week. 2 weeks, your signal should, something should ring, something is wrong. So that's between normal and abnormal, right? The psychological symptoms. The second, in the algorithm, the second most important thing is are these symptoms or are they part of a disorder? Because psychiatry is only clinical. See, disorder is only a cluster of signs and symptoms, right? You don't have any tests. So you say, okay, I'll do a test. Nothing, sorry. So what do you need to know? Is there marked personal distress? So if there's no marked personal distress, it's likely to be just symptoms. When it's starting to get into a disorder, it's going to give you, somebody with a obsessive compulsive disorder is going to be personally distressed. Except in 2 situations. When there's psychosis, for example, in mania or in schizophrenia, any psychotic condition, when there's no insight. So when there's no insight, sometimes there's no personal distress, right? Somebody's hallucinating, has delusions, and so in that case, the second thing which you look for is socio-occupational decline. Very, very important. If there's no socio-occupational decline, it's unlikely to be a disorder. It's unlikely to be a disorder. So what are you looking at? Social decline. Patient doesn't want to go out. Patient doesn't want to go to work. Somebody's coming over, go lock themselves in their room and say, I'm not in a mood. They're avoiding social situations. They are avoiding occupational situations, work, school, college. They just can't handle it. A point of caution here, if it's somebody like Dr. K.K. Agarwal, somebody whose normal day is what, 16 hours, 18 hours, that gentleman or lady going down to occupational decline of 10 hours, people may not notice it. So that is a word of caution. A lot of people, what we're talking about is achieving your potential, whatever was your highest potential, that if there is a decline in that. So a lot of times I would talk to women and काम हो जाता है घर का, बस मुझे ही पता है मैं कैसे कर रही हूँ, किसी तरह से बच्चों को स्कूल भेज देती हूँ, खाना बना, so then when they tell you that, it's a decline. It's a decline, they're just pushing themselves, and at one point of time, it will collapse. So normal versus abnormal would be pervasive, persistent, remember the 2 P's. And after that, when we're looking at disorder versus symptoms, so which does not mean that you give up on the symptoms. So if you do not have marked personal distress or socio-occupational decline, your radar is still up. You're still, it could be an evolving mental illness. It could be something which has started, it could be something reactive to a situation. So you at least follow them up. And if you meet the duration criteria and if it persists for 2 weeks, I would refer to a psychiatrist. Unless you're so well versed with each mental illness and the diagnostic guidelines that you can confidently make a diagnosis. And if you can, it's great. But that's the spot when you don't want to mess up, because the management of panic disorder and major depressive disorder may be the same antidepressant agent. And it could work. SSRI would work for anxiety, it would work for depression. But do you want to give it for 6 months, 9 months, 1 year? Those are the essential questions. And a lot of times GPs would do that. You know, somebody comes with sadness, you start antidepressant, patient in 3 days is fine, in 1 week is fine. You know, the doctor gets the credit, you stop it. Maybe it should, typical compliance issues, the patient sometimes, on the other side of the fence.
Just hold on, somebody is asking the same question that time. Dr. Prem Sharma, Dr. Reshma, do you agree with Pranam Mukherjee that mental and general health care must be integrated? How can this be made a reality in terms of clinical offerings in multi-speciality and government setups?
Yes. So
and then another is Dr. Rajendra Kaul, who is asking hallucinations could be drug induced.
Yeah, I'll come to that. So the first question first. We were listening to, every specialist, when you talk to them, they seem like GPs should know about them, about their issues, right? Every specialist will say, a GP may mismanage this. A GP cannot possibly be, mini specialist of everything. And I used to always joke in my GP training programs that am I going to make a psychiatrist RMP, by giving a short, capsule?
Yeah.
But there's no other way out. Just like we used to have multi-purpose workers, you can't have the same person going to a house, saying, "Abhi main malaria ki baat karne aaya hu, ab main typhoid ki karne aaya hu, ab main polio ki karne aaya hu." You have to have that integration because nobody has time. Nobody has time for trainings in series. So you have to integrate not just mental health. I think all, the essentials of all what the GP should know, they should know. You can't have one chapter, in a medicine textbook which says manic depressive psychosis and depression, and that's it. And you come out and you can't blame anybody.
The complexity of the problem is many of the medical organic diseases, there is a component of psychiatric illness or tension precipitating or aggravating, and also the somatoform diseases.
Yeah.
And even dementia, organic dementia,
Sure.
So these are some of the challenges a practitioner normally face.
So my take on that is again related with the second question also, which I will come to later. The issue is that if a GP is well informed, if they're trying to treat everything, it's not possible. But at least the common mental disorders, anxiety, depression, common mental disorders, management is simple, diagnosis is simple. At least we can have capsules focused on the common, if you can, 75% in the Pareto principle, 75% of the issues can be handled. And then for the rest you can always refer. So I would go back to the definition of WHO. 1948 they have not been able to modify. There's been criticism, right? Health is a state of complete physical, mental, social well-being. That's my question to everybody. What is mental well-being? What is social well-being? Not even thought about it. Physical well-being, definitely, we will go to the gym, we will do this. So that's where what I am doing now is holistic wellness. If you try to run a three-wheel vehicle, we put a truck tire of physical well-being, and put a tricycle tire of social well-being, and put a cycle tire of mental well-being. If anybody wants to run that, good luck to them. For the rest of their life, if there's no harmony and balance between, WHO did not say, it will be 80% physical, it says physical, mental and social well-being. Nobody has ever, now, stress, suicide, so many mental health issues, everybody suddenly woken up and said, yeah, psychiatry, people are coming and asking me, somebody has sneezed, what is your opinion on that? Everybody wants me to talk about everything which is, so now there is over-psychiatrization of even normal stuff. Anything which is happening, they want a psychiatrist's opinion. What about social well-being? Nobody has a clue. Road rage, right? One scrape of a car and one murder happens. somebody wants to kill somebody, person has died, आप 32 बार चाकू लेके मार रहे हो. That's so social disorders. Those are social disorders. We have to look at them. Relationships are coming apart. Social media has taken over. Virtual friendships give no emotional or any kind of support. But most of people's lives are spent on, virtual socializing. Anyway, we will complicate the issues. But the fact is, if you do not pay equal attention to physical, mental, and social well-being, and that is why mental health issues must be integrated with the general health issues. Otherwise, there's no escape. If you do not teach a bit of psychology, a bit of counseling, even at school level, they're not ready for life. They're not, you're not preparing, you're not laying a good foundation. So that's one, I totally agree. How we can do it is to focus on the most important part as early as possible. On the most important part. Not just CMEs, why not at the medical education level?
Some quick answers. Should one rule out organic disorders first and then go towards functional problems?
Right.
This is Dr. Rajinder Kaul.
Yeah.
Then another one is
this
drug-induced
hallucinations.
hallucinations.
This with the hallucinations. So let me talk about
and
that.
one more. I mean, it looked like some patient of hers.
Mine?
No.
Oh, perhaps.
This is mania of singing. Should be required treatment.
Okay. So let's take because I was going to come to that anyway. So as I was saying, as a revision, pervasive over situations, persistent over time, abnormal. Personal distress, socio-occupational decline, maybe disorder. Maybe disorder, now, is it primary? Is it secondary? Primary is a primary mental illness. Secondary to, most important, you have to find out, is there any other comorbidity? Is there any medical illness? Patient has thyrotoxicosis, patient has vitamin B12 deficiency. Very common in this country. Vitamin D deficiency, vitamin B12 deficiency, it goes undetected. Even I had it when I first tried to check myself out, right? So many hidden causes, so many obvious causes. Somebody has diabetes, hypertension. So most important is, before you even diagnose, and every mental illness diagnostic guidelines say this, rule out general medical condition. So if you have a general medical condition, it may or may not be causing it. You must make sure that it is not causing it, because there will be a temporal correlation, So you know that, this is when it was diagnosed and this is when the symptoms began, number one. Number two, medications. Medications themselves can cause symptoms. Antihypertensives, anti-diabetic, so that's the number two thing. And number three, drugs. Drugs meaning, substances of abuse, alcohol, caffeine, most commonly abused psychotropic substance. Nobody thinks about that. Nicotine, right? So those very common, right? You don't even have to think about cannabis and opioids and other things. It's just these three things you have to figure. So you must rule out organic mental disorder before you diagnose a function. What used to be called functional, today there's no differentiation as such. All we say is it just a mental disorder by itself, or is it caused by something else? General medical condition, medications for any condition. And I will tell you, I was in my super specialty hospital, I had fights with cardiologists. Everybody with panic disorder, with panic attacks, was getting ECGs, etc. And I tell them, okay, I mean, let's not go to that extreme, but even ECG, how many times do you want to do an ECG for a panic attack? You do it once. I mean, the same person coming to you in the ER fourth time, at least at that time you think about something else, right? I would tell them, okay, I will have the confidence, listening. हमको तो कराना पड़ेगा because you don't do the workup. What if something happens? I can confidently tell whether a patient has panic disorder or some cardiac condition, because it's a cluster. You find 4 symptoms out of 13. 13 symptoms of panic attack are written everywhere. You Google it, you find it. 4 or more, it's a, patient is very clear. एक साथ बैठे बैठे 4 symptoms complain कर रहा है. Suddenly palpitation, suddenly पसीना आ रहा है, heartbeat goes up, symptoms. Within 1 hour, I feel better. And what? Yes, one time you can do an ECG or you can suspect. We cannot keep suspecting. So, just to take an example, there are so many times that if you are well armed with knowledge, you can reduce the misuse of medical facilities.
Just to interrupt.
Yeah. So hallucinations can definitely occur in organic conditions. Delirium.
मेरे हाथ कांप रहे हैं. मेरे पैर लड़खड़ा रहे हैं,
Uh-huh.
मेरे हाथ से धनुष छूट रहा है, मेरे रोंगटे खड़े हो रहे हैं और मुझे समझ में नहीं आ रहा है मैं क्या करूं.
That is the first example of psychotherapy, cognitive behavior therapy, which has been in history, recorded in history.
All these five of Arjun.
Panic attack,
Was an
yes.
acute panic
Yes,
attack.
absolutely.
This is what exactly 5 symptoms he described
Absolutely.
when he was talking to Lord Krishna in his first chapter of Bhagavad Gita.
It is the recorded cognitive behavior therapy which he did, and which worked. Which worked. So somebody had said about hallucinations, yes. And what about mania? They said,
Singing.
now, just like you can miss things, you can overdiagnose things. Maybe somebody is in a genuinely good mood, I don't know. So it's not just singing. So is the person spending excessive money? They are basically high, the reverse of depression. So their personality has changed. They're spending money, they're extroverted, they're cracking jokes, they're all over the place, their energy levels are very high. Okay, that reminds me, the other very important part which our friends should focus on is biological functioning. Appetite, sleep, energy levels, and libido, desire for sex. These are the 4 things which you must focus on, because if they're gone, there are very many chances of So sleep, appetite, mostly it will be down.
Appetite.
They can't sleep in some small percentage of depressive, atypical depression. Sleep more, but we are talking about rule of the thumb. Can't create psychiatry RFPs, remember. So rule of the thumb is sleep is reduced, appetite is reduced, energy level. Now energy level is a very, very important thing. First thing, we all know that, right? When we are little down, we have low energy. Suddenly, you're in a good mood, you hear a good news, you're full of energy. So that definitely, gets affected from here. And don't have to keep on, you try to do your hemoglobin and, a few basic tests. But that should raise your signals when your appetite, sleep, libido, very important, and energy levels. These 4 things. So that's the other thing where your radar goes up. So for my GP friends, I would say how to diagnose. Normal versus abnormal we talked about. Symptoms versus disorder we talked about. Again, rule of the thumb. Symptoms you do not treat with medications. Disorders, very likely you need medications. If it's a disorder, you can treat depression with cognitive behavior therapy, but at least in India, it takes time. You require trained professionals. So, and it's painstaking, you have to have belief in the system. But there are head-to-head studies where cognitive behavior therapy will work. But rule of the thumb, if you are able to diagnose a disorder, it's going to require medications. If it is symptoms, follow up the patient. Don't treat symptoms. That's the worst part. So worst part, start benzodiazepines. Very well, right? Uske baad, when you create dependence, then you can refer, and then a patient comes to me taking 20 tablets a night. I'm the bad guy, GP is the good guy, because sab kuch sahi chal raha tha. Okay, another word of caution. So diagnosis, I said. So when to refer, if you suspect a disorder, you find persistent, pervasive, socio-occupational decline, personal distress, organic ruled out, still there, refer to psychiatrist, let the patient get a diagnostic label, get the management started, patient will come back to you. Now you follow up the patient. What do you do in the follow-up? Most important, patients don't want to continue medications. Typical example, I diagnosed major depressive disorder. I started the patient on an SSRI, and because every psychotropic agent, mostly they're long acting, their half-life is long. So, 1 दिन का या 5 दिन तो steady state आने में लग जाता है. So by the time the drug starts to act, it will be at least 2 weeks. But what's the worst part? Side effects come immediately. So now here's the scenario. You prescribe an antidepressant, so you want to prescribe benzodiazepine, patient is distressed. Patient is going to be even more distressed when you start the medication. You start them on benzodiazepine. So you're given some alprazolam, some clonazepam, and antidepressant. What happens? Patient forgets 1 dose of antidepressant, feels much better. Patient forgets 1 dose of alprazolam, life is hell. So patient says, ये दवाई उतनी ज़रूरी नहीं है, ये बहुत ज़रूरी है. इसको बिल्कुल मुझे मिस नहीं करना. They are going to carry everything there and keep on forgetting this. Ultimately, what's going to happen when it's time to wean them off the benzodiazepine? They've taken that very faithfully, not taken this one. That's the messing. That's the mess up. So this is something that GPs should definitely know, that we are only using benzodiazepines as a stepping stone to a good level of the main
So
agent.
Sachin Khadilkar, he says, Sachin Khadilkar says, this hypomania needs treatment. And Dr. Kaul says extrovert versus introvert, which is normal.
Both are normal. So both are normal, and basically there is no concept of normalcy about mental health issues. So it's a spectrum. It's a spectrum. Always my rules will work. If there's no socio-occupational decline, if there's no personal distress, it's unlikely to be a disorder. So personality traits versus personality disorders, right? So if there are traits, we all have them. Somebody gets more angry, somebody's talkative, somebody's extrovert, introvert. But if somebody never talks, not able to do certain jobs, not able to interact socially, the social occupational decline, you are thinking of a disorder. Personality disorders get coded in DSM-4 on axis 2, ICD-10 part of the game. But if you find any abnormal symptoms which look like a disorder, get them assessed by a
But
specialist.
this chronic psychotic illness, where many of the people have to be on a long time
Yeah.
therapy, that is a major challenge.
So Dr. Sir, let me ask you, diabetes, hypertension, ulcerative colitis, you name any illness, lifelong treatment. Psychiatric illnesses, except for one or two, the toughest to deal with, obsessive compulsive disorder, right? Schizophrenia, yes. Psychosis may or may not need lifelong. Most other illnesses, 6 months, 1 year. But the trouble is, the minute the patient is well, they don't want to take it. Now what do you do with diabetic? You tell them, right? फिर रोकोगे तो तुम्हारा शुगर बढ़ जाएगा. It's going to get worse. Same thing with mental illness. Patient 2 weeks patiently ले लिया. Patient has gotten better. अब कहता अब क्यों खाऊं? अब तो बिल्कुल ठीक. अब उसको लगता है कि इनको पैसा मिल रहा है. Pharma companies इनको गिफ्ट देते होंगे. मुझे दवाई खिलाए चले जा रहे. So I have always used one paradigm which has worked very well. कि पेड़ कट गया है, जड़ बाकी है. आपका पेड़ कट गया है, दिख नहीं रहा है, जड़ बाकी है. जड़ को निकालने के लिए आपसे हाथ जोड़ के प्रार्थना है, खा लो. The other thing is, this is all based on studies. There's no test, so I can't do a test. So what is happening is, what we have found, 75% of patients will relapse if you stop it. But there is a 25% group which will not relapse. But I don't know which group is that. So I have to give it to you. You take your chances. You keep on coming back. Keep on coming back with depressive episodes. We are trying to sort of cure you for life, hoping to cure you for life. 1. 2, you said, does hypomania need to be treated? Yes, hypomania, a very mild form of mania, even 4 days, creates abnormality. Usually, they may subside on their own. Most of them go undetected. Most of them, when somebody will get a manic episode, or when you are very nicely taking history in a patient of depression, trying to rule out bipolar. Every patient of depression, you must rule out bipolar affective disorder before you start them on treatment. So when you take history कि कभी बहुत बड़ी बातें कर रहे थे, बहुत खर्चे कर रहे थे, सो नहीं रहे थे, sometimes they say हाँ कोई इतने दिन के लिए ऐसा होता है कभी-कभी, so you probably find it mostly gets skipped. Mostly patients don't seek treatment for that. वो लोग सोचते हैं कुछ अच्छे मूड में है, कुछ अच्छा हो रहा होगा इनके साथ. But yes, if you diagnose it, and then you have to keep the patient on follow-up, because patient is potentially bipolar affective disorder patient. And there's one more question which had come up in between. You said
Singing.
Yeah. So that's that. Like I said, you have to have a cluster of symptoms to make a disorder. You don't treat symptoms ever. Singing excessively will usually be accompanied by ITO पे खड़े होके 500 रुपए के नोट बांट रहे हैं. They'll be not sleeping, full of energy. उधर से उधर जा रहे हैं, गाने गा रहे हैं, साथ में सोने की जरूरत थी. There's actually decreased need for sleep. High energy levels, bounding, helping people. You'll tell a manic. If anybody has seen a manic, sometimes they get into aggression, fighting, become violent.
Doctor, now we have only 5 minutes left.
Yeah.
Let's talk about life skills. That is your expertise.
Yeah. So, okay. So, as a wrap up, I've already touched upon that. So, it's my firm belief that if I do not concentrate on the mental well-being and the social well-being, then I don't hope to achieve holistic wellness. I don't hope to achieve it. And it messes things up because everything is interlinked. Everything is, if your mental well-being is affected, or if your social well-being is affected, your physical well-being is going to be affected. When you talked about somatoform disorders, historically there were 7 illnesses. They said, okay, ulcerative colitis is skin problem. There's, the 7 illnesses are psychosomatic, which means this affects the body. Today, there is a psychosomatic element to every illness. Every illness. If you are stressed, your immunity is going down. I mean, I don't have to teach the basics to anybody. We know very well that psychological ill health is going to precipitate. Okay, there is a first hit, second hit. Everybody knows there's a genetic first hit, and there's a second hit waiting to happen, right? Any stress will precipitate an illness. Even cancer may not show up in many people, but shows up in some people. Something as bad as that. So my contention is, please focus on everything. Please have a three-wheeler with equal sized wheels. Focus on relationships. I don't have time for you, right? When you need me, then you don't have time for me when I need you. So it's a give and take. Make time for people. Focus on relationships. Make friends with neighbors. Make genuine friends, not virtual friends. ये के फोटो पे जाके लाइक इसलिए किया कि वो मेरे फोटो पे लाइक करेगा. I mean, it's sad but true. So focus on, okay, quick rewind. Physical, my easy formula is eat, exercise, sleep. Eat, exercise, sleep. EEZ. Physical well-being. Mental well-being, there are only 2 things we do: think and feel. Here, and the behavior gets reflected by thinking and feeling. Positive thinking, good emotional intelligence, what we call emotional quotient now. Handling your emotions, handling others' emotions, that part of it. Correct behavior. And social well-being is all about me and something outside me. Inanimate world, scenery, I mean, even dogs, pets, human beings, their relationships with everybody. Focus on all 3. Do not think that I'll work for 16 hours and do 4 hours of each. Sorry, it doesn't work that way. If you do not actively go out and work on your mental well-being and your social well-being, you cannot achieve holistic wellness. That's, if I had to cap it up.
You want to add, Alex?
Does financial well-being or financial status of a person or an occupational status of a person has any value on these issues?
This
about the
alone,
mental
yes.
health?
Those things will impact everywhere.
Yeah.
Become part of social.
Mental and social. Mental is all about your celebration and whatever work you're doing.
Mhm.
Social is again very important part of it. So, we're not getting into details of the components of physical, mental and social well-being. People have been trying to add spiritual dimension.
Yeah,
WHO is,
emotional and
WHO has
spiritual
not
and everything, yeah.
done that. But you have to subsume spiritual and financial and everybody under these 3. Mostly under the mental, because that's thinking and
This
feeling.
counseling definitely plays a major part, isn't it? Nowadays what we find is psychiatrists increasingly become not interested in the counseling part, and somebody, others are given
I'll give you a
the
one sentence
yeah.
answer. I'll give you a one sentence
Yeah.
answer. I was sometimes seeing 100 patients in a 4-hour OPD.
Yeah.
I didn't even have time to complete my prescription. I used to sit till 10 o'clock to tell, okay, आपको बात करनी है, बात करें. Forget counseling, आपको बात करनी है, please OPD के बाद में रुक जाओ. They would wait for 3 hours so they could catch 10 minutes. If we can change that, now, psychiatrists, there are, the number of psychiatrists, 3,000-4,000 psychiatrists, everybody is coming to us, so what you focus on, yes, now outside, and now there are budding counseling schools and psychotherapy schools, everybody teaching, everybody creating all kinds of RMPs that can harm also.
Yeah, exactly.
People lose faith sometimes. If you don't do it correctly, don't pick up the right patient, patients lose faith in the whole system.
Is there any link between
So
functional problem and Alzheimer's?
the lead role of the psychiatrist in doing counseling, you should not dilute it.
We used to train, we
yeah.
should train everybody in counseling. I have trained for, during HIV/AIDS, we had a lot of funds. We have gone and trained people in grief counseling, in HIV/AIDS counseling, pharmacists, people who are working in their job. Everybody needs to know the basic principles so that they can incorporate them. Every doctor should know the basic principles of counseling, because that helps. That helps with each patient. It
Please
helps.
discuss the functional problems from Alzheimer's.
Sorry?
Alzheimer's and functional problems.
Right. So Alzheimer's would be in that category of when I said you find symptoms and you rule out organic so Alzheimer's is one of the things which will cause anything. It can cause anything from delusions, hallucinations, anxiety, depression, everything. So but Alzheimer's is not difficult to diagnose. If you find Alzheimer's, it's likely that you handle that. It's like bucket with a hole. ना बाल्टी में छेद है तो आप बाल्टी का पहले छेद बंद करोगे. That's the organic part, the medications and the substance of abuse.
Psychiatric illness is usually a short duration, is it?
No, no.
And compared to when you differential diagnose between Alzheimer's, it's a chronic illness, slowly they become worse,
But the trouble comes because everything will start at some point. No, then you don't know. If you find a long-standing illness, it's easy. But if something is budding today, then Alzheimer's also budding today, then that'll be the tricky part. But you should, everything is organic unless proved otherwise. I'm saying that as a rule of thumb. You know why? Because you don't want to start treating depression and somebody's thyroid problem has gone from A to Z. So if you do not rule out organicity and just start treating the symptoms, that's why I always say, do not treat symptoms. Make a diagnosis, whether it's thyroid toxicosis or myxedema leading to depression, or it's a psychiatric major depressive disorder. When you make a diagnosis, you will not make a psychiatric disorder without ruling out organicity. So once you do that, everything is clear. I make a major depressive disorder, then I'm very confident. मुझे एक साल दवाई खिलाना है. I can convince the patient. But if I don't have a disorder, we're treating symptoms. Sorry.
Diagnosing time factor also important.
Yes, that's what I said. Persistent over time. So you can't mug up the duration of 100 illnesses. That is why the simplest thing is refer. If you gain patients' confidence, you refer the patient to a psychiatrist. They will come back to you for follow-up. So you got a patient for 1 year, you make 1 or 2 trips to a specialist and come back and do a good job.
Thank you.
So in half an hour, it's not possible to learn. It was possible in our MBBS date, but that's the only half an hour they give for mental health to teach. But not today's live, and we talk about physical, mental, and social health. So what we'll do is we'll request Reshma from Washington.
Yeah.
From Washington to be in touch with us on Skype, and we can have many more such
We've done
sessions.
so many GP trainings.
No, we can still do it from there.
Even there,
on
definitely. I'd be very happy to
We
share
can
what I
still
can.
do it with Skype. The only thing is we'll wake you at 3 o'clock in the night.
I don't sleep till 3.
It's 3 to 4.
I live on India time. I love India.
With that.
Thank you very much. Thank you.
That's all for today. We'll come back with one more session next Thursday at the same time. We thank our guest Reshma, and of course I with my team, Dr. Martanda Pillai, Dr. Monga, and Dr. Alex. We say goodbye to you and we'll see you next week.
And Merry Christmas.
Merry Christmas and Happy New Year.
And you were better than we expected you to be. You did very well.
इतना खराब impression किसने डाला?
बहुत बढ़िया था।